Atrial fibrillation, most common. Mm, okay. Mitral stenosis impairs the diastolic filling of the left ventricle and causes an increase in the left atrial pressure, which leads to uh, stretching of the left atrial wall. The atrial wall stretch can disrupt the electrical conduction and trigger arrhythmogenic electrical foci. Atrial fibrillation most commonly originate from the arrhythmogenic foci of the pulmonary veins. Atrial fibrillation can induce decompensated heart failure in the setting of the MS. Because many patients with MS require additional left ventricular filling supplied by atrial contraction, atrial kick at the end of the diastole to remain decompensated. Atrial fibrillation in the setting of MS also carries a higher thrombogenic risk than the non-valvular atrial fibrillation. Routine anticoagulation with warfarin is indicated regardless of Church-Vague score. So mitral stenosis carries a higher thrombogenic risk than the non-valvular atrial fibrillation. So in a valvular atrial fibrillation, warfarin should be given even if Church-Vague score is low. Okay, okay. Sorry. Yes, yes. If mitral stenosis causing AFib, then you need warfarin, even if the Church-Vague score is low, even if the Church-Vague score is 1. But if it is non-valvular atrial fib, then we need to see the Church-Vague score. If it is more than 2 for men, then we will give oral anticoagulant. If it is more than 3 for women, we will give uh, oral anticoagulant. And option C, left left atrial myxoma can obstruct the mitral valve and cause a presentation similar to MS. However, because the mitral valve is healthy, an opening snap would not be present. Thrombus may be seen in the left atrium in patients with MS, but it typically develops in the atrial appendages and would not be attached to the interatrial septum. Okay. Okay, so these patients, dyspnea, orthopnea, pulmonary edema, pulmonary edema, and lower extremity edema, or lower extremity swelling, S3 are S3 are consistent with decompensated heart failure, which is most likely due to myocarditis. Viral infection is the most common cause of myocarditis, and a number of viruses mm, have been implicated, including Coxsackie, parvovirus B19, human herpes virus 6, adenovirus, influenza, HIV, COVID-19. An adequate initial immune response may allow an inadequate initial immune response may allow virus to invade cardiomyocytes and cause contractile function. Viral myocarditis is commonly asymptomatic and resolve without being clinically detected. Heart failure is the most common symptomatic presentation. Heart failure is the most common symptomatic presentation. Decreased systolic function with ventricular dilatation. Decreased systolic function with ventricular dilatation, eccentric hypertrophy develops and may progress to DCM, may progress to dilated cardiomyopathy. Less commonly, patients have chest pain that can mimic myocardial infarction. Sudden cardiac death can occasionally be ventricular arrhythmia, and some patient describes viral proton fever, malaise, myalgia that precedes the development of cardiac symptoms but may not have such history. ECG with viral myocarditis typically shows non-specific ST segment changes in the setting of heart failure. Echocardiogram typically shows forced chamber dilatation with diffuse wall hypokinesis. Endomyocardial biopsy with viral PCR is diagnostic gold standard but is often deferred in favor of non-invasive cardiac imaging. Okay, it's not B. Coccidioidomycosis typically manifests with similar to community acquired pneumonia, fever, cough, fatigue. It's endemic in the southwestern US. In parts of Texas, however, its presentation with myocarditis and heart failure is rare. It's not CTD, connective tissue disease, like SLE, rheumatoid arthritis. It can cause rare cause of myocarditis, and DCM. Absence of skin rash, joint pain, underlying connective tissue disorder unlikely. Got it? Okay, it's IV diazepam. As because the nasal mucosa is atrophic, it's cocaine. Okay. Mm, this patient has psychomotor agitation, dilated pupil. This patient has psychomotor agitation, dilated pupil, atrophic nasal mucosa, hypertension, and acute MI, chest pain, ECG with ST segment elevation. Sorry, ECG with ST segment depression and T wave inversion, finding highly suggestive of acute cocaine intoxication. Cocaine potentiates sympathomimetic actions by inhibiting norepinephrine reuptake into the sympathetic neuron. These stimulates alpha and beta adrenergic receptor. These stimulates alpha and beta adrenergic receptor and can result in vasoconstriction and increased heart rate, systemic blood pressure, and myocardial oxygen demand. It also enhances thrombus formation by promoting platelet activation and aggregation. All patients with cocaine toxicity and myocardial ischemia, all patients with acute cocaine toxicity and myocardial ischemia should be treated initially with supplemental oxygen and intravenous benzodiazepine by reducing sympathetic blood flow. Benzodiazepine, diazepam reduce anxiety, agitation, lower blood pressure, heart rate, and alleviates cardiovascular symptoms. Aspirin slows thrombus formation. Nitrates and calcium channel blocker vasodilator are beneficial for cocaine-induced coronary artery vasoconstriction. Beta blockers include cardioselective agents metoprolol, latimolol, bisoprolol. Generally should not be used to treat cocaine-induced myocardial ischemia or infarction until the cocaine has been eliminated from the patient's body. The use of theoretically co- the these their use can theoretically cause unopposed alpha adrenergic stimulation and worsen coronary vasoconstriction. Although some retrospective studies and case reports suggest beta blocker administration is safe in patients with cocaine intoxication. Methodological limitations and bias may limit the of their result. Validity of their results. Mixed alpha and beta blocker may be safe, but overall evidence is limited. Okay. High. Normal jugular venous pressure. If it is more than 3 centimeter of water, it is high. More than 3. Okay, this patient, if BNP and S3 gallop, uh, BNP and S3 gallop, these two are indicating for heart failure, isn't it? Like if somebody has a high anti-pro-BNP like BNP, then it indicates heart failure. Okay, these patients with nocturia, progressive exertional dyspnea has an evidence of volume overload, jugular venous distension, peripheral edema, which is suggestive of decompensated heart failure. An elevated BNP level strengthens the clinical diagnosis. Although some patients with decompensated heart failure may have falsely normal BNP level, the cause of dyspnea and decompensate the cause of dyspnea in decompensated heart failure is multifactorial and involves more than pulmonary edema alone. Increased ventilatory demand, ventilatory and peripheral muscle dysfunction. Therefore, the absence of pulmonary edema in the patient does not exclude the diagnosis of decompensated heart failure because patients with slowly progressive decompensation may have minimal or no pulmonary edema. This is because pulmonary lymphatics can gradually increase fluid outflow rate up to 10 times of the baseline when needed, effectively offloading fluid from pulmonary venous system to the central venous system, allowing evidence of elevated central venous pressure to be present despite minimal or no pulmonary edema. Central venous pressure is JBD plus something else. I forgot the thing. And it is more than 8 centimeter of water. Central venous pressure. We have done a question where we found the central venous pressure. Okay. And cardiomegaly may be absent if decompensated heart failure is due to left ventricular hypertrophy in the setting of chronic hypertension, resulting in diastolic dysfunction, impaired feeling. Okay. It's not deconditioning, although deconditioning can cause dyspnea on exertion. It would not explain JBT. It would not explain JBT, peripheral edema, or elevated BNP. Got it? Yes. No. AR is diagnosed via the pulse pressure, isn't it? Wide pulse pressure. You have, yes. AR is diagnosed by widened pulse pressure. Okay. Okay. This patient presentation is consistent with valvular AR due to bicuspid aortic valve. Bicuspid aortic valve is the type of congenital heart disease. Patients some cases develop sporadically, whereas some have Mendelian inheritance, autosomal dominant with incomplete penetrance, likely explaining this patient's family history. Although frequently associated with aortic stenosis, bicuspid aortic valve is also the most important cause of developed in AR in the developed countries. Patients with AR due to bicuspid aortic valve are typically diagnosed in their 30s or 40s and uh, age 10 years lower than that at which is due to bicuspid aortic valve presence. The AR can be asymptomatic, causes palpitation. AR can be asymptomatic, causes palpitation, chest pain, and dyspnea. It is usually valvular in nature. It is usually valvular in nature, presenting as decrescendo, early diastolic murmur, best heard at the left sternal border, with the best heard at the left sternal border, with the patient leaning forward, heart brought toward the chest wall, and holding a deep breath in expiration. Murmur easier to hear. Bicuspid aortic valve is associated with aortic root dilatation, which can also cause AR. With AR due to aortic root dilatation, the murmur is best heard at the right upper sternal border, reflecting the turbulent blood flow around the aortic root. Aortic root dilatation can progress to aortic aneurysm and dissection, sometimes causing sudden death. Okay, it's not HCM, hypertrophic cardiomyopathy. Although associated with a positive family history, sudden cardiac death, HCM typically presents with harsh crescendo, decrescendo, systolic murmur, harsh crescendo, decrescendo, systolic murmur that is best heard at the left sternal border, and that increases with maneuvers, that decreases left ventricular volume, valsalva, and decreases with left ventricular volume like valsalva, and decreases with maneuver that increase left ventricular volume, that is squatting. Okay. Okay, it's free wall rupture. Okay, first we will go through the box. Okay, papillary muscle. First, acute or 3 to 5 days. What will happen in 3 to 5 days? What are the complication can happen in three acute or three within 3 to 5 days after MI? Papillary muscle rupture or dysfunction and interventricular septal rupture. Papillary muscle rupture involved coronary arteries RCA. RCA. It can come with severe pulmonary edema, respiratory distress, new soft systolic murmur, hypotension, cardiogenic shock. And on echocardiography finding, we will find severe MI. So papillary muscle rupture, RCA, severe MR. Interventricular septal rupture, again 3 to 5 days acute or within 3 to 5 days LAD, apical septal or RCA, basal septal. Interventricular septal rupture, chest pain, new harsh holosystolic murmur with thrill. Chest pain, new harsh holosystolic murmur with thrill. Hypertension or cardiogenic shock. Left to right shunt. Left to right shunt. And a free wall rupture within 5 days up to 2 weeks. Within 5 days up to 2 weeks, it is LAD. Chest pain, distant heart sound, shock, rapid progression to the cardiac arrest, pericardial effusion with tamponade. Pericardial effusion with tamponade. So acute 3 to 5 days. Acute 3 to 5 days is papillary muscle rupture, interventricular septal rupture. 5 days to up to 2 weeks is free wall rupture, and left ventricular aneurysm is up to several months. In here there is LAD involvement, LAD, heart failure, angina, ventricular arrhythmia, thin dyskinetic myocardial valve. Thin dyskinetic myocardial valve. Okay, okay, now the explanation. The patients experience cardiac arrest most likely due to cardiac tamponade, from a left ventricular free wall rupture. Left ventricular free wall rupture is a mechanical complication of the MI that can occur. Mechanical complication of the MI that can occur up to 2 weeks following transmural MI, with 50% of the cases occurring within 5 days of MI. It most commonly complicates MI affecting the left anterior descending artery LAD, because the anterior left ventricle wall must withstand high left ventricular pressure and is prone to high shear stress. Delayed reperfusion or no reperfusion increases the risk due to more extensive myocardial necrosis. Left ventricular free wall rupture typically presents with sudden onset chest pain as blood fills the pericardial space. Cardiac tamponade rapidly develops and leads to obstructive shock with hypertension and tachycardia within minutes or less. Uh, cardiac output markedly drops and pulsatile electrical activity ensues. Pulsatile electrical activity refers to cardiac arrest occurring with a potentially perfusing rhythm junctional but no palpable pulse. It often has a potentially reversible causes. Has a reversible causes. Okay, reversible causes are 5H, 5T, we know. 5H, hypovolemia, hypoxia, hydrogen ion like acidosis, hypokalemia and hypothermia, and 5T, tension, pneumothorax, tamponade, toxin, thrombosis and trauma. Okay, these box can be remembered like this complication, like you can remember the pitfall, the complication, the above. Have you played the game Pitfall in your early days? Okay, we actually, this is a very old game, like 90s game, like when there is Xbox or this type which is very popular, or earlier than Xbox. This type of game, this game is played by us, like Pitfall, Pitfall. The mnemonic does not fit everything, but the main thing comes, like papillary muscle rupture, P, interventricular septal rupture, F, free wall rupture, and L is left ventricular aneurysm. That's why this is Pitfall. Okay, so so free wall rupture, F for free wall rupture, and L for left ventricular aneurysm. Left ventricular aneurysm. Okay, okay. The papillary muscle rupture. Remember it as a PROM, like papillary muscle rupture, RCA, and MR, PROM, PROM, like prom night. So you can remember the papillary muscle rupture is PROM, like papillary muscle rupture, RCA, and severe MR. Why I am saying this? Because apart from papillary muscle rupture, every one involves the LAD mostly, like interventricular septal rupture, free wall rupture, and left ventricular aneurysm. LAD, left anterior descending artery, is involved, but papillary muscle rupture involves the RCA. Got it? Filled R for P for papillary muscle rupture, R for RCA. O and M for MR. There is no O. O is actually who my heart is lying down. Like hypotension, he is in shock. So, failing heart. Think in that way. Okay. And other like interventricular septal rupture comes with look the new harsh systolic murmur. But papillary muscle is, as it is muscle, papillary muscle, it is comes with new soft systolic murmur, but interventricular septal rupture, as the interventricular septal rupture comes with harsh systolic murmur. Okay, you can differentiate. And free wall rupture always comes with the tamponade, like hypotension, distended neck vein, distant heart zone, and left ventricular aneurysm comes with the features of the ventricular arrhythmia or heart failure. Got it? This box is very vital. That's why I have discussed so much. Okay. In this condition, we need to do Chad's-Vac score, isn't it? Yes, because when there is non-valvular, no valve is involved here. Non-valvular atrial fibrillation comes with the Chad's-Vac, and in Chad's-Vac, just look, he is men, so he gets 1 point. So age 65 to 70, less than 65 is 1, I think so, and 65 to something else is point 0.2 as far I remember. And he has hypertension, diabetes. So Chadsbeck has hypertension, diabetes. So it is, I think that it is more than 3 or 3 plus, isn't it? Peripheral arterial disease, you can give aspirin to. Yes. And another drug like in peripheral arterial disease, like if you think that peripheral vascular disease, it comes with the claudication, isn't it? And in peripheral vascular disease, you can give silostazole too. Silostazole works in the claudication, like silosta. Yes. So if we think on that perspective, then you can give multiple things. Okay. Okay. I am reading the explanation now. This patient with acute lower extremity pain, this patient with acute lower extremity pain, paresthesia, pulses, nets, has acute limb ischemia. Acute limb ischemia, given the patient's history of paroxysmal lateral fibrillation and irregular pulse on examination, the most likely cause is embolism of the left atrial thrombus, which might have been prevented, by appropriate anticoagulation therapy. Current guideline recommend the use of CHATS VAC score for the thromboembolic risk. For the thromboembolic risk assessment, men with CHATS VAC score more than 2, such as these patients, score 3, hypertension, diabetes, and age 65 to 74. Women with score more than 3 are at high risk of thromboembolic event, should be managed with anticoagulation therapy. In this patient, the benefit in this patient, the benefits of lower embolization risk outweighs the risk of bleeding, intracranial hemorrhage. Okay. Okay, apixaban. Apixaban is a direct oral anticoagulant. It's a direct oral anticoagulant that inhibits the factor 10A, preventing it preventing it cleaving prothrombin to thrombin. The direct oral anticoagulant, including direct thrombin inhibitor, dabigatran, direct 10 inhibitor, direct 10 inhibitor like apixaban, rivaroxaban, edoxaban, significantly reduce systemic embolization risk with similar or superior efficacy to warfarin, but with decreased risk of severe bleeding like hemorrhagic stroke and no need for routine INR testing. In contrast, antiplatelet therapy with aspirin antiplatelet therapy with aspirin in combination antiplatelet therapy with aspirin or a combination of aspirin and clopidogrel is significantly less effective in reducing thromboembolic risk compared with anticoagulant therapy with direct oral anticoagulant or warfarin. Okay, yes. Silostazole is a phosphodiesterase inhibitor. Uh, occasionally used for symptomatic management of patients with intermittent claudication, which typically presents more chronically with exertional leg pain. Although Silostar also suppresses the platelet coagulation, it is not indicated for primary thromboembolic event prevention in patients with atrial fibrillation. Not yes. Okay. No, ST elevation in the one AVL is ST elevation, but 2, 3, and AVF has ST depression. And other like V1 is normal, I think. So V2 to V6 there is ST elevation. So it's look like anterior lateral MI. Looks like. One AVL goes for lateral MI, and as the V1 to V6 lead is ST elevated, looks like anterior lateral MI. Yes, I think that immediate cardiac catheterization time has passed, isn't it? It is like 90 minutes, and 2 hours is 120 minutes. Okay, yes, we can still do it. We can give thrombolytics. The telemetry. We are wrong. Okay, even if 90 minutes passed, we okay. So we need to read the PCI one. So okay, I'm reading from the prompt, like prompt coronary perfusion. This one is very important. Okay, okay. So this patient's clinical feature. So this patient clinical features an ECG finding ST elevation, lead 1 AVL and V2 to V6 with reciprocal ST depression 2-3 AVF. I have already said that ST depression in 2-3 AVF and ST elevation in 1 AVL and V2 to V6. Okay, so suggest anterolateral ST elevated MI due to a left anterior descending artery occlusion. In patients with typical presentation, ST elevated MI can be diagnosed even without cardiac biomarkers. Can be normal early on. Immediate coronary reperfusion therapy. Immediate coronary reperfusion therapy is indicated following initial stabilization measures, which includes oxygen, full dose aspirin, platelet, platelet 2Y12 receptor blocker, clopidogrel, ticagrelor, and nitroglycerin relieves ischemic pain, and morphine if nitroglycerin is inadequate, beta blocker, and anticoagulation. So look at this point. Like in here, they have used everything as because it is not inferior MI. Because inferior MI comes with a bradycardia, but it does not comes with the bradycardia. So in here you can use nitroglycerin, you can use beta blocker, you can use and other options are. Got it? Okay. Prompt coronary reperfusion with primary PCI, prompt coronary reperfusion with primary PCI or fibrinolytic therapy. Altiplase restores the blood flow, limits myocardial damage, reduce mortality. Current guideline recommend primary PCI for patients with acute ST-elevated MI as follows: within 12 hours of symptoms onset and within 90 minutes from first medical contact to device time at a PSI capable facility, or within 120 minutes from first medical contact to device time at non-PCI capable facility to allow time for transport to a PCI capable facility. So multiple randomized trial have shown lower rates of recurrent MI and intracranial hemorrhage and improved survival with primary PCI compared to fibrinolytic therapy. These patients who is within 24 hours of symptom onset 2 hours ago at a PCI capable facility should ideally undergo PCI within 90 minutes of first medical contact. Fibrinolysis is recommended for ST-elevated MI. Fibrinolysis is recommended for ST-elevated MI patients arriving within 12 hours of symptom onset who cannot undergo PCI. PCI is not available within the recommended time frame. So okay. So main concern in here, so we can do PCI within 12 hours of symptom onset, and the most valuable is the most important if this if that hospital has PCI capable setting, so it should be done within 90 minutes. If that hospital does not have PCI capable setting, so refer to a PCI capable setting within 120 minutes. So these two are very best. And the patient who is within 12 hours symptom onset 2 hours ago and at a PCI capable facility should ideally undergo PCI within 90 minutes as a first. Okay, fibrinolysis is recommended for ST-elevated MI arriving within 12 hours of the symptom onset who cannot undergo PCI, and PCI is not available. Okay, so after 2 hours, we should go for fibrinolysis like altiplase, retiplase if the patient comes within 12 hours of symptom onset. Got it? Is it uh, okay? Like, look at the trick here. Within 90 minutes from first medical contact to device time. So if somebody has chest pain, he is in the home and he called 999, and when 999 comes to that patient, so it is the time for first medical contact. Got it? So from that first medical contact to PCI capable facility, like this 999 hospital is connected with the John Hopkins. Like this patient goes to the John Hopkins where there is PCI capable facility. So this should be done within 90 minutes from first medical contact to the device time. Got it? And and uh, and like if that hospital is not John Hopkins, or if it is the local hospital where there is a no PCI capable setting, because lots of hospitals do not have the PCI capable facility. So then you have to refer the patient to the nearby PCI capable setting. That's why the time there needs some time for transportation of that patient. So that's why the time frame should be within 120 minutes. Got it? Yeah. From first medical contact to the device. Eh, the first medical contact to device is not the point where the chest pain starts. Got it? That's why these points are so tricky. Like I have chest pain. Now from this time, I only need 90 minutes to do PCI. That's how you are thinking, isn't it? Like you have started chest pain from now to 90 minutes you have to do PCI. You are thinking, okay, yes, yes. When they find you with when they find you that you have chest pain, shortness of breath, hypotension, confusion, and they can, I think that they have the facility of doing ECG too. ECG is a ECG can be done in the ambulance also. So if they do ECG and this ECG is referred to the hospital, because they are all of them are connected to the doctors, isn't it? So they send the ECG to the doctor, and the doctor found and doctor sees that the ECG has ST elevation. So before coming the patient, they actually start do the setting of doing PCI. Got it? I think that that's how these things go. In Bangladesh, it is not like that. In Bangladesh, it is very hard to do PCI. We actually do post PCI. My father has got non-ST elevated MI, so we have done I we have done PCI, not primary PCI. We have done post PCI because in non-ST elevated MI actually you don't need PCI. So I admitted my father and I give the fibrin low molecular weight heparin like anticoagulant for a week. Then we do like see sorry then we do a test of angiogram, coronary artery angiogram. Then in angiogram there is multiple blocks. One of the blocks is more than 90%, like LED is more than 90% involvement, so we put stent, so we do a stenting. So it is post PCI, like putting a stent on the patient. This can be done. You got it? I know I explain a lot because this is very confusing. I know. Yes, whatever what you are seeing in the question, because the chest pain beginning 2 hours ago. So he has already passed 2 hours. Yes, so when the emergency first comes to the patient, first touches the patient, the clock starts from then to 90 minutes. but it should be the next point, but it should be within 12 hours of the symptom onset. They have said in the first, look at the 3 point. That's why I am emphasizing this 3 point within 12 hours. But like you have chest pain 15 hours ago, now you are starting to doing PCI. It is not, it's not like that, because you most of the patient you will I have seen in the cardiology department, like you give aspirin, you give the loading dose of aspirin, clopidogrel, and you give the atorvastatin. The patient actually improves within a minute. But what happens in the what happens in this patient? The we need to monitor. We need to admit the patient, because the troponin I actually rises uh, as the time passes. Troponin I actually rises after 6 hours. Okay. Okay. WPW's Wolf Parkinson White syndrome. Pathophysiology involves ventricular pre-excitation due to accessory pathway that conducts depolarization directly from the atria to the ventricle. It competes with normal conduction. It competes with normal conduction through AV node. The mixed ventricular depolarization manifests on ECG, short PR interval, shortened PR interval, slurred upstroke, that is delta wave. Uh, this is the slurred upstroke, short PR interval. Normal PR interval is 3 to 5 small square. If it is less than 3 small square, it is short PR interval. Okay. Widen QRS complex classic for WPW syndrome. WPW is defined as the development of paroxysmal supraventricular tachyarrhythmia in patients with WPW pattern. The most common arrhythmia seen in WPW syndrome is AVNRT. However, pre-excited atrial fibrillation can occur. Its characteristics ECG pattern is an irregular rhythm with wide QRF complex of variable morphology reflecting variable depolarization from either the accessory pathway or AV node. Pre-excited atrial fibrillation can lead to extremely fast extremely fast ventricular rate that can deteriorate into the V fib, The rapid rates develop due to difference in the conduction characteristics between that AV node and the accessory pathway. In the AV node, slow calcium slow calcium current prevents the rapid conduction to the ventricle. In contrast, the accessory pathway is similar to the atrial and ventricular myocardium phase 0, conducted to the phase control sodium channels, allowing. Okay, in the AV node, the slow calcium current prevents the rapid conduction to the ventricle. In contrast, the accessory pathway is similar to atrial and ventricular myocardium phase 0, controlled by sodium current, allowing rapid atrioventricular conduction. Acute treatment for pre-excited atrial fibrillation. If, if the patient is hemodynamically unstable, it requires immediate synchronized electrical cardioversion. If the patient is hemodynamically stable, as in this patient, it can receive medical therapy to slow down the accessory pathway and reduce the ventricular rate and or possibly converse the sinus rhythm. Procainamide is a class 1 antiarrhythmic agent that inhibits cardiac sodium channel and usually the drug of choice because it slows conduction through the accessory pathway without affecting the conduction through the AV node. Got it? Okay. Medication that slow conduction through the AV node, including adenosine, digoxin, verapamil, beta blocker, should be avoided in pre-excited AFib because they encourage their further conduction through accessory pathway. So it can, in pre-excited atrial fibrillation, you should avoid, like there is this is the contrast. Like in atrial fibrillation, like we actually give beta blocker and rate limiting calcium channel blocker and digoxin, isn't it, to control the rate. But in pre-excited AFib, along with it has WPW syndrome. So pre-excited AFib, because they encourage further conduction through the accessory pathway, so we are avoided these drugs. Therefore, they risk increased ventricular contraction rate even higher and exacerbating the risk of VFib. Class Choice C, lidocaine, is a class 1B antiarrhythmic drug that inhibits cardiac sodium channel, but it is not effective for supraventricular arrhythmia, including pre-excited atrial fibrillation. It is sometimes used for ventricular arrhythmia. Got it? Okay, next. I was thinking this, but I again done the wrong. Okay. Okay, it's coarctation of the aorta. Coarctation of the aorta. These patients elevated blood pressure and ECG finding consistent with the left ventricular hypertrophy. ECG finding consistent with the left ventricular hypertrophy. High voltage QRS complex, lateral ST, segment depression and lateral T inversion. High voltage QRS, lateral ST, segment depression and lateral T inversion are suggestive of long-standing hypertension. Essential hypertension rarely leads to end organ damage in young patients. Essential hypertension rarely leads to end organ damage. Left ventricular hypertrophy in young patient age less than 40. Therefore, cause of secondary hypertension should be sought. Coarctation of the aorta is the narrowing of the descending aorta, typically located just distal to the origin of the left subclavian artery, that results in a proximal increase in the arterial pressure and decreased blood flow to the lower body. Patients usually present with asymptomatic hypertension. However, epistaxis, headache, lower extremity claudication can occur. A continuous murmur is characteristically associated with coarctation of the aorta, but is always noted and may be particularly difficult to auscultate in supine position. Evaluated Patients should be initially evaluated for coarctation of the aorta. Simultaneous palpation of the brachial and the femoral pulse to assess the brachiofemoral delay. Bilateral upper extremity supine position and the lower extremity prone position blood pressure measurement to evaluate upper and the lower extremity blood pressure differential. Patients with abnormal findings should undergo diagnostic confirmation with echo. Got it? Okay. Okay. Okay.